Hello, everyone. I am Dr. Alan Bonder. I am an associate professor of medicine at Harvard Medical School and the medical director of liver transplantation. And also my research interests have been cholestatic liver disease, specifically PBC and PSC. I'm here to talk to you about first kind of like the integration of AASLD guidelines on patients with PBC. What I'd like to barely start is the diagnosis of PBC. The current guidelines recommended 2 out of 3 of the following should be met before diagnosis of patient with PBC. So we have a positive anti-mitochondrial antibody, or AMA, and cholestatic liver injury, specifically an elevation of the alkaline phosphatase. And if any of those 2 are not present, liver biopsy findings of primary biliary cholangitis. And we talk about the histology findings as, bile duct injuries, granulomas, lymphocytic cholangitis, which basically give the diagnosis of PBC to the patients. So it comes to the next part of that clinical guidelines. So the current guidelines use UDCA, or ursodeoxycholic acid, at dose of 13 to 15 milligrams per kilogram of body weight on a daily basis as the first-line therapy. In multiple studies, UDCA has shown that can decrease the liver enzymes, decrease lipids, decrease the need of liver transplants, and normalizing portal hypertension. So UDCA currently, as I just said, it is a first-line therapy and is what's recommended by our clinical guidelines. But UDCA has not had 100% response and will need some type of second-line therapies. And this is when risk stratification and risk assessment of this patient is so crucial. What we know today is there's certain type of patients will likely respond or not respond to this therapy. For example, what we know that younger males with higher alkaline phosphatase or an elevation of the bilirubins are less likely to respond to the therapies. Also, we know based on the clinical guidelines that elevation of the elastography, or we call it in practice FibroScan, also have been shown to show poor liver outcomes. So when we actually try to stratify those patients, this is the tools that we have in clinic that we can provide patients if they're going to be responders or non-responders. The next thing that we need to really discuss is who do we refer as patients as primary or non-responders. So responders means that your alkaline phosphatase goes below 1.67 of the upper limit of normal. This is just based in the POISE clinical trial that was published in the New England Journal of Medicine back in 2016. And again, so those patients who get UDCA, who lower the alkaline phosphatase below this threshold are considered responders, and they don't need any further therapies by the current guidelines. On the contrary, for those patients who do not respond, so the alkaline phosphatase remains elevated above the 1.67, and have elevation of either the FibroScan or other markers, are those patients who will benefit from second-line therapies currently. As everyone is aware, the FDA has multiple medications approved for the second-line therapy, and I will go quickly describing them to you. So in 2016, based on the POISE clinical trial, the FDA approved obeticholic acid. This was in a randomized study that showed that patients who were treated with this medication had a better chances of responding, 46% versus placebo, 10% getting that threshold of alkaline phosphatase below the 1.67. Unfortunately, this medication has gone some more thorough scrutiny, and in 2021, the FDA issued a box warning of patients dying with portal hypertension. And then currently, there's still a discussion about this medication's approval because of the risk of liver decompensation. So the current practice or the current guidelines recommend that those patients who are on obeticholic acid, as we call it OCA, if they have cirrhosis with portal hypertension, should be stopped and switching to a different agent. The good news is back in the summer of 2024, the FDA issued approval. So now we have 3 new therapies that we can use as kind of the standard of care of patients with PBC. One more important thing that is so important to discuss is we have new medications to assess the response but we don't not really doing a good job managing symptoms and quality of life. This is where, for example, the 3 most common symptoms of patients with PBC come around. So fatigue, itching, and abdominal pain are very common and really are very bothersome to our patients. And it's really an important thing that we need to address, assess, and give them the right therapies. So currently, there are medications in clinical trials designed specifically to treat this condition, but also those 2 new medications that were just approved in the summer of 2024 has shown some really improvement in their symptoms and really show promising results to treat symptoms in the future in assessing the quality of life in patients with PBC. And finally, I would like to talk about what are we doing today in clinics. So personally, what I do in patients who come to see me, put them in UDCA, assess the risk, make sure that they're responding. And if they're not responding by 6 to 12 months, trying to get them in a second-line therapy or in a clinical trial so they can try to get their liver test as much as normal as we can. And for the future, I think we are looking at what the new normal will look like. And I would say for us who really treat patients with PBC, we should aim for a new normal, meaning all liver tests should be normal, not only looking at the 1.67, and also adding good quality of life of our patients. So we have seen significant improvement in treating those symptoms with the new therapies and then with the new therapies in the pipeline. So I'm very positive to see that in the near future, we will have a full remission and almost full cure with these patients with the current therapies. One more other thing that is so important to mention. Those patients who do not respond and those patients who, despite doing everything that we have available, including second-line therapies, third-line therapies, and clinical trials, some patients still need liver transplant. So those patients whose bilirubin still is going up, the alkaline phosphatase is not able to be lowered, they are an increased risk of progressing to complications of liver disease, portal hypertension, and those patients should be referred to a liver transplant center for being listed in possible liver transplant as soon as possible. So I just want to kind of summarize that PBC has really very good new therapies, and we have really good tools to assess responsive to the current therapies and future therapies. So if you have any other further questions, just please look at the GAP website, and really hope you guys get to enjoy this in detail.